Good evening, sir. I extend my gratitude to Dr. Georgie Nanan, sir, and Renal Pharma for providing this platform for this case presentation. And I also thank faculties of Trivandrum Medical College for constant guidance and support. And directly going to my case. My patient is a 24-year-old male from Trivandrum working in Technopark as quality assurance engineer with a comorbidity of hypothyroidism, presented to our neurology department with chief complaints of blurring of vision for 2 days, headache for 1 day. History of present illness. He developed sudden onset of blurring of vision while working on a laptop, more pronounced on the right eye. There is no history of pain on eye movement, watering, giddiness, weakness, or numbness. On day 2, he developed mild occipital headache, not associated with nausea, vomiting, photophobia, or phonophobia. On further probing, he also gave history of 1 episode of low-grade fever 6 days back, gradual onset generalized fatigue for 6 months, and exertional dyspnea and palpitation for 2 weeks. No history of bulbar, motor, or sensory symptoms. No history of TNT, orthopnea, chest pain, cough, hemoptysis. Past history, he was diagnosed to have hypothyroidism 6 months back, evaluated due to severe fatigue, and TSH was 30, and he was on 50 microgram thyroxine. Personal history, unmarried, mixed diet, no addictions. On examination, initial examination in neurology, he was conscious oriented, thin built, weight was only 45 kg, BMI was 16, BP was 180 by 140 mmHg in left upper limb, pulse rate was 86 per minute, normal volume, temperature was normal, JVP not raised, pallor was there, pedal edema was there, no rashes or ulcers. Higher mental functions were normal, visual acuity, right eye 6 by 60, left eye 6 by 36. Fundus examination showed evidence of papillary edema, dot and blot hemorrhages. No motor sensory cerebral signs, no neck stiffness, other systems were within normal limit. So initial investigation in neurology department, there was anemia, hemoglobin 10, platelet was about 1.67, ESR was 55, CRP 14.8, HbA1c was normal, urea was 56, creatinine was 2.1, and total bilirubin was elevated 1.8, OTPT was raised 121 and 108, albumin was 3.6, and urine examination showed albumin of 3+, RBC 3 to 4, then urine PCR of 9.007, 24-hour urine protein 2.5 gram, urine culture and sensitivity, no bacteriuria. Viral markers were negative, CSF study was normal, TSH was 13, LDH was 900, peripheral smear, no evidence of hemolysis. And MRI showed evidence of pus, CKMB was elevated 165, and trophy was persistently elevated. And they have done an echocardiography which showed ejection fraction of 38%, concentric LVH, global hypokinesia of LAD, LCS, RC territory, mild pericardial effusion. So they sort of nephrology opinion. So our scenario is an young male with hypertensive emergency, renal impairment, subnephrotic proteinuria, and microscopic hematuria. So on further probing from our side, he revealed multiple joint pain and myalgia for the past 6 months, and he consulted an Ayurvedic physician. BP at that time was 150/90. Took Ayurvedic medicine for 5 days and didn't follow up further. He had significant weight loss of 10 kg over past 6 months. No history of frothing of urine, hematuria, facial puffiness, no history of recurrent UTI. On our examination, BP was 140/90 mmHg in both upper limb. He was on 3 antihypertensive then. Lower limb BP was 150/90. Peripheral pulses were palpable and equal. No carotid or renal proving. So a differential diagnosis we considered initially was a SLE lupus nephritis with a TMA or APLA. He was a young male, even though sex is not preferring for SLE. There is associated renal impairment, hypertension, subnephrotic proteinuria, hematuria, serositis, multiple joint pain, constitutional symptom in the form of fatigue, weight loss, LV dysfunction probably due to myocarditis. Second DD we considered the IgA nephropathy with the vasculitis, again same glomerular involvement, hypertension, constitutional symptoms, but there were no skin lesions or abdominal pain. And another DD was primary TMA, young male presenting with a hypertensive emergency and renal impairment. And renovascular hypertension because of the hypertensive emergency, end organ damage, reflex nephropathy since he's an young male, subnephrotic proteinuria, severe hypertension. And another DD considered was ANCA-associated vasculitis, even though the age is not preferring for ANCA. But in EGPA, with the cardiovascular involvement. The age group is 30 to 50, so we considered ANCA also, but there is no histopathologic or upper respiratory symptoms. And another diagnosis differential was MPGN or IRGN. Then we advised a USG abdomen and renal artery Doppler. And USG abdomen showed a right kidney mild hydronephrosis, left kidney 8.2 into 4 centimeter, bilateral pleural effusion, mild ascites. Renal artery Doppler was normal. So we shifted the patient to nephrology for further evaluation and renal biopsy. Further investigation in our department, C3, C4 was normal, ANA 2 plus positive, ANA profile was negative, APLA panel was negative, CNCAP was positive, but we did a PR3 which is negative, PNCAP was negative, and 24-hour urine oxalate 11.6, viral markers were negative, including HPV DNA PCR. And on the course of illness, patient developed right-sided flank pain. And in view of mild hydronephrosis in the ultrasound, we went ahead with a CT abdomen. We showed right kidney bulky, and they have mentioned that there is a moderate hydronephrosis with the proximal ureter dilatation with the upper ureteric calculi. And they, along with this, they have mentioned some 5 to 6 hypodense area in both kidney, corecollection or infarct. And there was associated moderate ascites, cardiomegaly, mild pericardial effusion, splenomegaly, bilateral pleural effusion left more than right. Liver appears normal, no filling defect. So his creatinine worsened from 2.1 to 6.18. So we give few sessions of dialysis in view of upcoming renal biopsy also. Right DJ stenting for right proximal ureteric calculi was done. And on the course of illness, he developed multiple vesicles in both upper limb and lower limb, sparing the trunk. So we sought a dermatology opinion. They treated it as atypical varicella, and they didn't find any typical features of the varicella in Stansmere. And after treatment of varicella, we planned for renal biopsy after a contrast study, since CT abdomen showed some hypodense lesion suspecting infarct. So in view of suspicious infarct-like lesion, we considered several other DBs also, like TMA with the various etiology, renal artery thrombosis seen in SL with the APLA, medium vessel vasculitis, large vessel vasculitis like Takayasu with the renal involvement, renal artery dissection as an FMD, but FMD, there is non-inflammatory condition, so down the list, and down the list another DD was atherosclerotic or cardioembolic disease. So initially we went ahead with the CT urogram, and they mentioned the contrast filled the outpouching from bilateral renal artery choreaneurysm. So in view of this, we went ahead with the CT iotogram, and CT iotogram showed this picture. CT iotogram showed a multiple tiny contrast-filled outpouching in the segmental and interlobar arteries. And we can see some black area, hypodense area, which is nothing but infarct. Actually, main renal artery was normal. The contrast-filled outpouching, that is aneurysm, are in the segmental and interlobar arteries. We can see here also. This is an infarct, hypodense area. So CT iotogram suggestive of multiple aneurysms in the segmental and interlobar artery, and they mentioned also the aneurysms in hepatic artery also. So medium vessels are involved, renal artery and hepatic artery are involved. So summary: young onset hypertension, constitutional symptoms, significant weight loss, hypertension emergency, non-oliguric renal failure, LV dysfunction, CT iotogram showing aneurysm in medium vessel, renal and hepatic. Then another one is subnephrotic proteinuria and microscopic hematuria. What about this? Then we considered a DD of polyarteritis nodosa. And after CT urogram, before starting immunosuppression, we repeated the urine routine. It showed no active urine sediments. RBC was not there. Repeat 24-hour urine protein was 445. So according to ACR criteria for polyarteritis nodosa, these are the criteria: weight loss more than or equal to 4 kg, libido reticularis, testicular pain, myalgia, weakness, mononeuritis multiplex, diastolic BP more than 90 mm Hg, elevated blood urea nitrogen or creatinine level, hepatitis B virus, arteriographic abnormality, biopsy proven leukocytoclastic lesion. So our patient had 5 criteria: weight loss more than 4 kg, weakness or fatigue, diastolic BP more than 90, elevated blood urea nitrogen and creatinine, and arteriographic abnormality. So course of illness, we gave injection needle prednisolone 500 mg and tap Visolone 1 mg per kg was given. And patient received a total 3 doses of cyclophosphamide, 2 weeks interval. But the serum creatinine remained persistently elevated between 2.5 to 3.5. And on the course of illness, he reported intermittent episodes of palpitation. Propy was consistently elevated. And cardiology review was given, which showed ejection fraction actually improved from 38% to 44%. And they advised a cardiac MRI. It showed LV hypertrophy. There were no evidence of myocarditis. This cardiac MRI was done after 2 doses of cyclophosphamide. And we asked for a coronary angiogram, but because of the aneurysm, they deferred. And other thing we could have done is the CT coronary angiogram, but already we did 2 contrast CT. So we went ahead with immunosuppression. And in between, after 3 doses of cyclophosphamide, my patient had 1 episode of culture positive UTA treated with IV antibiotics. Subsequently, patient developed pancytopenia with diarrhea, including 1 episode of hematochezia, and there was no history of abdominal pain. And medical gastroenterology consultation showed colonoscopy relieved mild proctitis and small hemorrhoids, and tissue CMV PCR came as positive. So we started him on IV ganciclovir. Then after 1 week, his cytopenia resolved totally, and he was discharged to home with an instruction to continue IV ganciclovir at a nearby hospital. And next day, we received a distressing call from his father that the patient had suddenly collapsed at home after complaining of severe fatigue. And he was immediately taken to a nearby hospital where he was declared brought dead on arrival. So the most probable cause of death could be a cardiovascular. We are thinking that the most common cause of this mortality in this patient could be a cardiac origin, because they are more prone for myocarditis, coronary artery vasculitis, and aneurysmal rupture. So we reviewed certain literature which also showed.
Sony, we are running short of time, please.
So in this patient, we had small vesicular lesion, and when we are reviewing the literature, vesicular eruptions can occur in polyarteritis nodosa. And the 5-factor score is a validated score which assesses the severity and predict the mortality in PAN, which are proteinuria more than 1 gram per day, renal insufficiency, creatinine more than 1.5, cardiomyopathy, severe gastrointestinal involvement, central nervous system involvement. More than or equal to 2 indicates severe disease. Our patient's 5-factor score was 3. And this is the treatment protocol like that of anti-vasculitis. Cyclophosphamide regimen is same as that of anti-vasculitis. So outcome, actually 25% of patients with PAN die within first 7 years. And the various studies showed the negative prognostic factors are the cardiac involvement, creatinine more than 1.6, and patient more than 60 years. And non-HEPB associated PAN have high mortality when compared to HEPB associated. So take-home message is cardiovascular complication in PAN is common and underdiagnosed. Coronary artery vasculitis, aneurysm, myocardial necrosis, and heart failure are the main culprit. PAN should be considered a cardiovascular emergency in patients with unexplained cardiac symptoms and vasculitis history.